Shall we start now?
Okay.
Good afternoon, everyone. Thank you for joining for our third session of this month. Today, our topic will be surviving a fall in the older person. The speaker of the day is Dr. Lim Wan Jie from Hospital Taiping, and the chairperson will be Dr. King Junni from Hospital Seberang Jaya. Please welcome Dr. King Junni.
Hello, good afternoon, ladies and gentlemen. Welcome and thank you for turning in to our third week of geriatric webinars organized by the College of Physicians Malaysia. My name is King Junni. It's my pleasure today to introduce our speaker this afternoon, Dr. Lim Wan Jie, who will speak to us on the topic titled Surviving Fall in the Older Person, the role of Orthogeriatrics and Fracture License Services. So Dr. Lim Wan Jie is a clinical fellow in geriatric medicines. He's currently practicing in Hospital Taiping. He obtained his postgraduate in internal medicines from MRCP UK, and he does his subspecialty training in geriatric medicines with Ministry of Health. I believe he's the best person to speak to us today on this topic because Dr. Lim recently set up a hip fracture clinic in Hospital Taiping amidst this COVID pandemic. I would like to also inform the audience in the end of Dr. Lim's talk, we will have a Q&A session. So if you have any questions, you can leave it on the Q&A tab that you could find on the bottom of your screen. So without further ado, shall we pass to Dr. Lim Wan Jie and let's listen to him.
Okay, good afternoon, everyone. Welcome to the third geriatrics webinar of the month. It's an honor to be given the opportunity to present for the College of Physicians geriatric webinar series. So I hope everyone's been keeping safe. The topic of webinar today is surviving a fall in the older person, the role of orthogeriatrics and fracture license services. So in this webinar, we're going to venture a little bit outside of familiar grounds of our medical wards and clinics to an area which is traditionally associated with the orthopedics department, that is falls and fractures in the older person. Wait, how come I cannot advance my slides? Okay. So for today's webinar, I will talk to you on the burden of falls and fractures in the older person. And then I will touch on the secondary prevention of fractures and falls. Then we will also examine the factors that constitute an acute admission for the older person. And I will introduce you to orthogeriatrics and fracture license services and show you how they fit into the management of falls and fractures in the older person. Then I will share my brief experience starting an orthogeriatric and fracture license service in Taiping Hospital. So what is a fall? It's simply an event in which a person comes to rest on the ground or floor or other lower levels. So something like this or like this. So falls are actually quite a significant problem globally. It accounts for about 10 to 15% of all ED visits and is the second leading cause of death due to unintentional injuries. It causes almost 700,000 fatalities a year and leads to a lot of disability-adjusted life years and presentations for medical attention. So for context, the total deaths due to COVID-19 in the USA as of early July was still less than the global annual falls fatality. And falls affect the older person disproportionately more than younger people. So for one, the prevalence of falls increases with age. Likewise, fatal falls rate also increases with age, with the highest rate of fatal falls occurring among the oldest men. Women tend to fall more than men, but when men fall, it's more likely to be fatal. Falls also confer significant morbidity in the older person. It makes up about more than 50% of injury-related hospitalizations in older person, mainly due to hip fractures, traumatic brain injuries, and upper limb injuries. And an acute admission following fall is associated with long lengths of stay and increases the risk of being discharged to a care home. Hip fractures are one of the most important causes of morbidity and mortality following a fall in the older person. and about 10 to 15% of all falls in the older person results in a hip fracture. They increase inpatient and outpatient mortality, and more than half of the patients who suffer from hip fracture do not regain their pre-fracture mobility and will have some essential activities of daily living, difficulty with some essential activities of daily living for up to 1 year after a hip fracture. So what is the cause of a hip fracture? The direct cost of treating a hip fracture has been estimated, at least in Malaysia, at about 6,000 US dollars, or roughly 25,000 Malaysian ringgit when converted. At an estimated 5,880 fractures a year, this translates to a direct cost of about 147 million per year. But this figure of 5,880 hip fractures a year is likely an underestimate, as our neighbors, Singapore, estimate that they treat about 4,477 hip fractures a year, and their population is much less than ours. Furthermore, due to population aging, the number of hip fractures are projected to increase over time. So by about 2050, we'll have about 3.6 times more hip fractures than we have currently. And of course, the direct cost of a hip fracture is but the tip of the iceberg. It is more difficult to estimate indirect costs, but let's just illustrate one example of indirect costs. So this is Malaysia's population pyramid in 1985. It's widest at the base here. And this is Malaysia's population pyramid in 2045. It no longer looks like a pyramid, looks more like a tower. Well, this is due to a combination of reduced birth rate and increased life expectancy. So the base of the 1985 pyramid now resides here. And by then, most of these people would be beginning their life after retirement. They will be supported by this group of working age adults. And by the time these working age adults reach retirement, they will be supported by an increasingly narrower base. And so in 30 years' time, a working age adult will have to support about 3 times more older adults when compared to present. So not only does an aging population mean more fractures, it also means less working age people to support them. This would result in an increased need for carers, decreased productivity, independence, and quality of life. And if not kept in check, this rising morbidity from falls would overwhelm the healthcare and support systems. To keep up, we need to reduce falls and fractures in the older person. We also need to improve outcomes after an acute admission for a fall and fracture. So what can we do? I'm going to explain to you using these key concepts. That falls lead to more falls, that osteoporosis increases fracture risk, and the period after a fracture is the period of greatest vulnerability, but also the greatest opportunity for intervention. Let's begin by talking about falls leading to more falls. After a fall, about 40% of older people fall again within a year. So let's examine this cycle of falls to understand why. Okay, there are usually factors that contribute to an initial fall. But even if we put these factors aside, after an acute fall may lead to injury, which causes pain, and physical changes which impair physical function. It can also lead to psychological and social changes by instilling fear of falls or reducing social interaction. This results in impaired, reduced physical function, which translates to a loss of muscle and bone strength and predisposes to further falls and fractures. So this cycle will perpetuate, leading to more and more morbidity. So to break this cycle, external factors must be applied. Comorbidities managed, beliefs modified, intervention given, and compliance ensured. So how does a falls intervention function in practice? So let me give you an example. When you ride a 40,000 ringgit bike and it hits a pothole on the road and you fall face first on the roadside, this is the result. The cause of the fall is the potholes. So to prevent such occurrences in the future, the pothole should be patched, ideally within 24 hours. So that is the basis of a falls intervention. So when it comes to falls risk factor, it's important to realize that some risk factors are modifiable, whereas others are non-modifiable. So if you're a penguin and you live in Antarctica, you can't change the environment that you live in, well, unless global warming melts all the ice. But proper intervention can either prevent falls or reduce severity of injury. So without these handrails, for example, the falls would have been much worse. You can classify falls risk factors by dividing them into intrinsic falls risk factors and extrinsic risk factors, as well as modifiable and non-modifiable factors. So intrinsic risk factors are risk factors inherent to the individual, like age, frailty, cognitive impairment, visual impairment, weakness, balance issues, while extrinsic factors are factors related to the external environment, things like lighting, clutter, footwear, and assistive devices. Our aim is to find risk factors that are potentially modifiable and to focus our intervention on these factors. In terms of falls prevention, there are several resources available online that you can refer to. I particularly like the resources available through the STEADY initiative by CDC. They provide comprehensive material to enable anyone to start a falls assessment and intervention service. And this is the STEADY algorithm for falls screening, assessment, and intervention. So it's as easy as 1, 2, 3. Step 1, screen. Step 2, assess. And step 3, intervene. So step 1 is to screen for falls risk factor via the use of a question tool or by asking key questions on history of falls, fear of falls, and unsteadiness. This is the questionnaire for falls risk screening assessment. It's a self-administered questionnaire and it contains 12 items which assess falls risk through question items on areas such as balance, mobility, falls, incontinence, and mood. Step 2 is to assess for falls risk factors. And a falls risk factor checklist is available for download in the STEADY website. This is very convenient for those who want to start their falls intervention service. You will notice that the assessment spans multiple domains. So evaluation is best done through a multidisciplinary team. I mean, while possible to do alone, it will take a lot of time and resources to do so. But with the multidisciplinary team, you'll be able to go through this list faster. So they provide other tools in the website too for use of the multidisciplinary team. So example is this community pharmacist falls risk checklist, as well as instructions on how to perform balance and mobility assessments for the physiotherapist, and a template for self-identification of environmental falls risk at home for the occupational therapist. But of course, if you might find that your multidisciplinary team might already have their own set of tools at their disposal. Step 3 is to institute the appropriate interventions based on identified falls risks. Suggested interventions of which are covered in the algorithm as well. So once interventions are given, you want to review their response and plan subsequent follow-up. So after a fall, it's good to screen, assess, and intervene. Next, let's examine this statement. Osteoporosis increases fracture risk. So osteoporosis is defined by low bone mass due to a deterioration of bone tissue, which disrupts bone microarchitecture, which compromises bone strength and increases risk of fracture. It has been termed a pediatric disease with geriatric consequences. That's because bone mass markedly increases during puberty and it reaches peak at around the age of 30 years old. And then bone mass gradually decreases throughout the lifetime. And in women, menopause accelerates the rate of bone mass loss. So with a low bone mass, fragility fractures can happen. Fragility fractures are fractures resulting from mechanical forces that don't normally cause fractures. So for example, falling down from standing height does not normally result in a fracture, but in patients with osteoporosis, it may happen. In fact, you don't even need to suffer from trauma to get a fragility fracture. In patients with osteoporosis, you may incidentally find vertebral compression fractures without a previous history of trauma. A diagnosis of osteoporosis can be made on any postmenopausal women or men over the age of 50 years old if they have a BMD done with a BMD T-score of less than -2.5. Or they could have a T-score that's between -1 and -2.5, and a high fracture risk as assessed by risk score assessment tools like the FRAG score, or a T-score between -1 and -2.5 in the presence of a fragility fracture in the proximal humerus, pelvis, or distal forearm. You can also diagnose osteoporosis without a BMD in patients with evidence of hip or spine fragility fractures. For fracture risk assessment, we commonly employ the FRAG score, and this is available online. Just remember to select our neighbor, Singapore, as the region, as there's at present no Malaysian data for calculation. And the problem with diagnosis of osteoporosis is that in Malaysia, one BMD serves about 500,000 people. And so it may be difficult to secure a BMD appointment for patients who live outside of cities and the central region. Take the example of Taiping, where I'm working at right now. It currently has no functioning BMD machines. In order to do a BMD, patients will have to go to Ipoh. So it's fortunate that we do not require BMD results in order to diagnose osteoporosis. A fragility fracture in the spine or hip would be good enough to clinch the diagnosis. And earlier I mentioned that vertebral fractures can occur even without a preceding trauma. So we could also potentially screen for osteoporosis by reviewing vertebral X-rays for evidence of fragility fractures. If you are equipped with the appropriate resources, do consider this in the future to screen for potential patients for osteoporosis treatment. So, well, the good news is osteoporosis can be treated and fragility fractures can be prevented. We just need to provide adequate calcium and vitamin D via dietary intake or supplementation, promote physical activity and lifestyle changes such as alcohol or smoking cessation, and provide pharmacological therapy where appropriate, and to identify and treat secondary causes of osteoporosis. A lot of diseases and external factors may accelerate the rate of bone mass loss. So these are what we call the secondary causes of osteoporosis. And because these factors may be treatable, it's important to identify these secondary causes of osteoporosis as part of your management of osteoporosis. We will not go into an in-depth view on the management of osteoporosis. It's outside the scope of this talk, but there are plenty of resources available online for you to refer to if you are interested. Our own CPG on the management of osteoporosis was created in 2012 and updated in 2015. And if I'm not mistaken, an updated local CPG on osteoporosis is currently in the pipeline. And there are many guidelines available internationally on the management of osteoporosis. So you could also refer to that. Or you could keep an eye out for online webinars on osteoporosis, like this upcoming one by Dr. J.K. Lee in August. And who treats osteoporosis? Actually, a lot of different medical branches manage and treat osteoporosis. There's orthopedics, there's the general practitioner, there's the internal medicine physician, rheumatology, endocrinology, geriatrics, and even gynecology. But all too often, you find them pushing cases to each other, and that nobody ultimately takes charge of osteoporosis management. This is especially true for secondary prevention of osteoporosis. So poor osteoporosis gets forgotten. As a result, osteoporosis treatment rates in Malaysia remain low. And in a study done in a Malaysian private hospital, only 36.8% of patients admitted with hip fracture get prescribed with at least calcium or vitamin D, not calcium and vitamin D, at least calcium or vitamin D. And only 27.9% of these patients receive osteoporosis treatment. And of those that do receive osteoporosis treatment, the mean duration of treatment was only slightly more than 1 month. And in Taiping Hospital, treatment rates are not much better. In a very brief audit done earlier this year on patients admitted to the orthopedic ward with hip fracture, only 26.7% had calcium, vitamin D supplementation, and only 6.7% received osteoporosis treatment. None of them were given a long-term follow-up plan for osteoporosis. So with the bar set so low in terms of current standards of osteoporosis care, any initiative to improve osteoporosis treatment in those with fragility fractures is likely to achieve a big impact with reasonably low effort. So if you're looking for a quality improvement project, this seems to be a low-hanging fruit. I mean, on an impact and effort matrix, these ventures are likely to fall somewhere over here. Easy wins. So we'll talk a bit about the implementation of a secondary osteoporosis, fracture prevention, osteoporosis care pathway later. Now, a patient who presents with hip fracture is likely to have suffered from other fragility fractures in the past. If osteoporosis and falls are left unaddressed, an initial fracture can lead to further fractures with progressively increasing morbidity. And since osteoporosis is treatable, and since falls intervention may reduce falls risk, each presentation with the fracture is an opportunity or a missed opportunity for intervention. Yeah, so the period after a fracture is the best opportunity for intervention to prevent further fractures via osteoporosis management and falls prevention. But it is also the period of greatest vulnerability. So let's talk about this next. Take the example of an acute hip fracture. It is a major event and causes significant mortality and morbidity. What makes an older adult more vulnerable to adverse outcomes after an acute admission is due to an interaction between comorbidities, disability, and frailty. Multiple comorbidities is usually associated with polypharmacy, and the interaction between these factors often complicate treatment decisions. Disability makes assessment difficult and predisposes patients to complications and makes rehabilitation difficult. Frailty is a state of increased vulnerability to adverse outcome. So this can be either physical, like medical outcomes, medical complications, or it can be cognitive, like being susceptible to delirium, or it can be social, where an acute admission might test your social support system. So the end result is that patients may be more susceptible to adverse outcomes, things like infection, bed sore, delirium, depression, or even being placed in a nursing home upon discharge. And to elaborate a bit more on frailty in an older person, the frail older person frequently does not return to their pre-morbid level of functioning after an acute admission. So during an acute admission, the older person is subject to negative influences, things such as inflammatory insult, delirium, iatrogenesis. Frailty makes the older patient more vulnerable to these insults. So this will result in a progressively worsening function and challenge their social support system and predisposes them to further ward admissions after discharge. So with each subsequent admission, things get progressively worse. Now, the idea is that if we take positive measures, we give positive influences during the admission, we may potentially reduce complications and deterioration. And we could also potentially reduce length of stay, reduce future admissions, and maintain function. With that in mind, what value can a geriatrician offer in a domain that's traditionally orthopedics? So let me illustrate with a typical example of Mrs. X, an 81-year-old lady. She has diabetes, hypertension, CKD, has poor hearing and eyesight. She fell in the bathroom and suffered from an intertrochanteric hip fracture. She was brought to the ED in pain and was noted to have an acute kidney injury and anemia. She stayed with her husband. Her children live overseas, and she had no living relatives nearby to call on for support. What are her needs during this acute admission? Well, she has underlying diabetes, hypertension, CKD, and she also has pain and presented with an AKI and anemia. So these factors need to be addressed, and she must be optimized for her hip fracture surgery. So complications also need to be prevented or managed if they happen. And her osteoporosis treatment later on, once she gets out of all this, also need to be planned. Her delirium also should be addressed by accounting for her needs. So bear in mind that she was in pain, she had vision and hearing impairment, and she was in an unfamiliar environment with an acute problem. Then physically, measures need to be taken to prevent deconditioning and pressure ulcers, and she will need rehabilitation post-op. Discharge planning also needs to be made. So she stays with the husband, children are overseas, there's no one around to support them. So will her husband be able to handle her at home on discharge? Are they able to afford paying for treatment? So, and upon discharge also, I saw someone raising the hand here. Should I be answering this or should we leave it for Q&A later?
Later.
Later. Okay. Sure. So basically, this holistic approach to the assessment of a patient is called the comprehensive geriatric assessment, and it is the bread and butter of a geriatrician. So let me share with you a geriatrician's secret. We don't do this alone because comprehensive assessments of a patient is quite taxing, and it is best done not by the individual, but by the multidisciplinary team. So you can learn a lot about a patient by talking to the nurse in charge, the pharmacist, the physiotherapist, the dietitian, for example. And orthogeriatrics is basically just the application of a comprehensive geriatric assessment in patients with acute hip fractures. So in the traditional model of care, the orthopedics department takes charge of management, and they are supported by the NS team perioperatively. And the geriatrics team or other physicians are only called upon as needed. In the orthogeriatric care model, the geriatrician is more involved, and several models of orthogeriatrics care exist. There's the geriatric consultation model, where patients are managed in the orthopedics ward, and the geriatrician comes for regular consults. There's also the orthogeriatric co-management model, where the responsibility is shared equally by the geriatrics and orthopedics team in a shared ward. And there is a geriatric lab model, where the geriatrician takes charge of patient care, and the orthopedic surgeon functions as a consult for hip fracture management. Now, which model is most suitable largely depends on individual healthcare settings. Orthogeriatric care has been shown to improve mortality, reduce length of stay, increase diagnosis and treatment of osteoporosis. And as illustrated in KL General Hospital, after implementation of orthogeriatric service, they managed to reduce time to admission, time to surgery, rate of pressure ulcers, increased rate of osteoporosis treatment, and implement false assessment in patient. Very impressive outcomes, I would say. And orthogeriatrics is now recognized as a standard of care for hip fractures, and is mentioned in many hip fracture management guidelines, though they may not specifically refer to it as orthogeriatrics. And as far as guidance or guidelines that we can refer to as to what we can do hip fracture in an older person, the Malaysian Society of Geriatric Medicine has released a position statement on false and fragility fractures. So it could serve as a guide for implementing orthogeriatric care. And is orthogeriatrics strictly a geriatrician's domain? Well, never mind the name orthogeriatrics, but I don't see why an internal medicine physician cannot take over the responsibilities of a geriatrician in an orthogeriatric system. So what are the functions of a geriatrician in orthogeriatrics team? Well, there are quite a few functions, and this list is not exhaustive, but is to champion for prompt and adequate pain management, champion for early surgery, early mobilization, is to optimize comorbidities and complications, identify and manage delirium, provide input on osteoporosis treatment, false assessment, and to facilitate rehabilitation and discharge planning. And also, this is quite important, is also to recognize when palliative care may be more appropriate. So most of these responsibilities are shared with the orthopedics and the multidisciplinary team. And I don't see why an internal medicine physician can't take over these responsibilities with a bit of learning and training. But of course, if you're going so deep down the rabbit hole, why not take the leap and join us? Geriatrics has been one of the fastest growing specialty in some countries, subspecialty in some countries, and I'm sure it'll be the case here in Malaysia as well. So join us. Yeah, so falls lead to more falls. Osteoporosis increases fracture risk, and the period after a fracture is the best opportunity for intervention, both in terms of fracture prevention and optimizing acute hip fracture outcomes. we talked about how implementing orthogeriatric service could potentially improve patient outcomes after acute fracture. Next, we are going to talk about how we can capitalize on these acute presentations for fragility fractures for secondary fracture prevention. We can do this through a fracture license service. So what is a fracture license service, or FLS for short? It's a coordinator-based mechanism for secondary fracture prevention, where patients with fragility fractures are proactively identified for fracture risk assessment and intervention. So here's how it works. So why various mechanisms, and the setting could be inpatient or outpatient. Fragility fractures are identified, okay, and they are then screened and investigated for fracture risk. Then treatment is initiated. It could be various means, education, lifestyle modification, falls prevention, pharmacotherapy, and finally comes integration, where information is shared with the relevant specialty or doctor to ensure continuity of follow-up and treatment. So identify, investigate, initiate, and integrate. So 4 I's. To ensure this is implemented properly, periodic quality assurance needs to be done. And given the variability of available resources in different healthcare settings, it might not be feasible to implement a full-fledged fracture license service right from the beginning. So, but there are different levels to FLS care. So it theoretically allows for incremental applications of FLS care. So you could start from a 0-I model, where patients with fragility fractures are educated on osteoporosis care, but cases are not identified for further action. So in this model, any further action is taken on, the patients are left to their own devices to decide on the next course of action. Then you could evolve to a 1-I model, basically where the FLS coordinator is alerted to a fragility fracture, and they arrange for a referral to the relevant healthcare providers for further investigation and treatment of the fragility fractures. Then you could move up to a 2-I model, where patients are identified and investigation done, but management of the fragility fracture is left to the outside doctors. And finally, you can move to a 3-I model, where you investigate, identify, investigate, and also initiate treatment for these patients to prevent future fragility fractures. So integration, the 4th I that I mentioned earlier, is the mechanism by which we refer to another healthcare provider for follow-up treatment. It has been estimated that an FLS, if applied in Malaysia with 75% identification of fracture risk and 75% adherence to treatment, will result in 2,881 bed days saved and a cost saving of $2.7 million or about 10 million Malaysian ringgit over 5 years. And for those who are interested to begin an FLS, is there a way to benchmark our service and see if it's up to standard? Yes, there is. There's the IOF Capture the Fracture program. So it's similar to the World Stroke Organization ANGELS initiative. This Capture the Fracture program was developed by the International Osteoporosis Foundation to facilitate the implementation of quality FLS worldwide, because they reckon that the implementation of an FLS is the single most important thing that can be done to directly improve patient care and reduce spiraling fracture-related healthcare costs worldwide. So the IOF came up with this best practice framework for us to strive towards an internationally recognized FLS. So there are 13 items in this framework: patient identification, patient evaluation, post-fracture assessment timing, vertebral fracture assessment, guideline-based management, screening for secondary osteoporosis, falls prevention service, lifestyle and health risk assessment, medication initiation, medication review, strategy for communicating information to other healthcare providers, long-term management, and the provision of a database. And based on your compliance to the best practice framework, you can get mapped on the map of best practice, where ratings go from gold, silver, bronze, and new FLS. So in Malaysia, there are currently 4 hospitals mapped, and they're all in the KL and Selangor region. The first hospital they mapped was a private hospital, Beacon Hospital, and its coordinator is an orthopedic surgeon, Datuk J.K. Lee, who also happens to be the current president of the FFNM, the Fragility Fracture Network Malaysia. So if anyone here is interested in starting an FLS, and this doesn't have to be limited to the inpatient, it could be limited, it could also be in the outpatient setting as well. Joining the FFNM might be a good starting place. It is a network of fragility fracture experts in Malaysia with a mission to promote and improve fragility fracture care. And at the moment, they are organizing FLS training courses for those who are interested. The first one we held virtually this Saturday, and there's already over 100 registered participants, more than we have anticipated, and hopefully not more than we can handle, with registrants from Singapore as well. It will be a recurring event, so do keep alert for any future notifications. And finally, we are at the end, or the final part of my webinar. Allow me to share my humble experiences in starting an orthogeriatric and fracture license service in Taiping Hospital. So I returned to Taiping Hospital in January this year as a final year fellow in geriatrics. And as part of my training, I'm required to conduct a project during my final year. So when I came back, I discovered that hip fracture care in Taiping has stayed pretty much the same way that it was 11 years back when I began my career in medicine in Taiping. So why not start an orthogeriatric or fracture license service here, focused on hip fractures? So I did some reading and came up with a proposal, and I created a timeline. Ultimately, I didn't adhere to this timeline, but it helped me to focus and plan on what needs to be done. Then I sought potential stakeholders from multiple disciplines, showed them my proposal, and recruited them. Well, in retrospect, I could have taken some pictures during this stage so that I can show you my team of stakeholders. And together, we mapped the journey of an older person with acute hip fracture. Among other things, we discovered the following: that there was currently no active capture of hip fracture cases. Hip fractures were mainly managed by the orthopedics team in their ward in collaboration with the NS team, the NS team for perioperative care, and the medical team was engaged only when necessary. And there was no dedicated post-op rehab pathway. Sometimes they utilize the house officers to mobilize the patient post-operatively. And our BMD machines were out of order, and there were no private centers locally that offered BMD scans. And osteoporosis treatment was limited to but several drug choices. And Klinik Kesihatan was at present unable to prescribe osteoporosis treatment, so because it was not under the AACE list. So we then proceeded with a preliminary audit to learn more about the current state of hip fracture care in Taiping Hospital. We found that the patient's length of stay was relatively short, at a median of 3 days. That's very, very short actually when compared to other hip fracture care service around Malaysia. And we found that 80% of them received operation, out of which more than 90% were operated on within 48 hours of admission. Yep, again, it's very, very good actually. And about half of them were seen by a physiotherapist while inpatient, though not necessarily post-operatively. Some of them may see the physiotherapist pre-operatively. And about only 6.7% received osteoporosis treatment, and only 26.7% were prescribed with calcium and vitamin D. And in terms of long-term bone plan, I couldn't find it documented in the notes of any of these patients. So let's compare this with the initial findings from HKL. The orthopedics department was actually doing remarkably well in terms of time to operation, and the length of stay was short. So basically what I'm trying to illustrate here is that it's important that you tailor your interventions to the healthcare setting and available resources. So you don't try to fix what is broken. And in this case, of course, I need to be careful that my interventions don't make these numbers look worse. These findings were presented to the stakeholders, and we decided on the following inclusion criteria for our FLS pathway: age 60 years or more, with hip fracture, who are pre-morbidly independent, with good family support. So yeah, we set up these inclusion criteria, but subsequently I've not strictly adhered to these inclusion criteria on several occasions. So then we came up with two pathways: the acute hip fracture pathway, which was our version of the Orthogeriatrics, and the bone clinic, which is an extension of the FLS, focused on osteoporosis treatment and falls prevention in post-hip fracture patients. Yeah. And we created a pro forma for data collection, and it also serves as a means to communicate information to the bone clinic upon discharge. So we don't require a referral letter for the bone clinic follow-up. We just require this pro forma to be filled up. And for false risk factor screening, why build something that already exists? So we just use the steady false risk factor checklist. And first we focus on the first I, right? Identification. So how do we capture our cases? So we capture our cases by using three mechanisms. First is a case capture QR code, which we place in the emergency department and orthopedic wards. And then next is via daily visits to the ortho ward to look for cases. And finally, by attaching the hip fracture pro forma to the notes of patients with hip fracture. So these notes will be sent to the bone clinic upon discharge from the ward, regardless of whether or not they get a bone clinic appointment. And daily ward rounds are made by the geriatrics team to review all hip fracture inpatients, with evaluation and management decided based on the principles of a comprehensive geriatric assessment. Investigation and false screening are started from inpatient, but of course we can't complete everything during the inpatient, so it's continued during the outpatient bone clinic follow-up. So one limiting factor here in terms of investigation is that we cannot easily arrange for BMD at the moment, but I hope things can change in the future. And finally, initiate. Treatment is started inpatient by the way of prescription of calcium and vitamin D. Osteoporosis treatment is also partly initiated inpatient, and for others, they are planned for initiation during the appointment in the bone clinic. So the ultimate aim later on is that to ensure continuity of care, right, integration, right, is that we can discharge these patients to the outpatient setting to continue osteoporosis treatment. Though at the moment, there's currently no mechanism in place to allow for discharge and follow-up in clinic kesihatan. So hopefully the clinic kesihatan can prescribe osteoporosis drugs soon. And the result is, at the end of May, we had our first bone clinic patient. So this is the patient. She is flanked by the daughter and the multidisciplinary team, comprising a community nurse, a pharmacist, a physiotherapist, an occupational therapist, and the geriatrics team, the geriatric doctors. Our clinic now runs weekly on Tuesdays. And so far, we have captured 25 patients with hip fractures via the mechanisms that I've stated. And of this number, about more than 20 patients have been given bone clinic appointments. And all of them have given appointments within 10 weeks from discharge. Of course, we can do that because this is a new service. So I also need to think about how we can continue this and ensure sustainability. So most of the patients were discharged with at least calcium and vitamin D prescription and an osteoporosis treatment plan, or they may have been started on osteoporosis treatment also. And of those who did not receive a plan, and this happens because if you notice earlier, I mentioned our length of stay is very short, like 3 days or so, right? So there were some that were admitted during the weekend after office hours and was discharged before we get to see on the next day, on the next working day. So of these patients, since we managed to capture them through our QR codes and through our bone pro forma, we were able to call 2/3 of them later for further follow-up and treatment. And we have managed to procure very limited doses of zoledronic acid for off-label use. And we are in the process of procuring some multivitamins for supplementations for patients who have vitamin D deficiency, because we do not have cholecalciferol here in we cannot easily prescribe vitamin D. So what we've been doing is that we've been asking patients to buy vitamin D on their own, but that can get quite costly. So we are looking for ways to treat the vitamin D deficient patients that we find. And of course, and this is the last slide. Of course, there's still plenty of room for improvement. For one, patients discharged from orthopedics still do not receive a complete prescription of meds upon discharge. And they also don't receive a complete discharge summary highlighting their problems. And I still need to come up with a database to capture all the treatment-related outcomes, and make it easier to perform quality assurance in the future. And I'm also conscious of the fact that my time in typing might be short. I'm due to transfer to Alasta in October, and I don't want my efforts to die off with my leaving. And well, if we are able to maintain this service until next year, I plan to get Taiping Hospital mapped under the IOF map of best practice. And in the process, prove to you that we don't have to be a centrally located hospital in Taipei, a centrally located hospital to get mapped. And so we come to the end of the webinar, and I hope you've been able to learn something from this webinar. And I also hope that I have inspired some of you to take the effort to come up with your own version of the FLS. Thank you for your time. And I guess it's time now for questions and answers.
Yes, Dr. Lim, thank you very much for your informative and interesting talk. I'm very pleased to hear your experience in Taiping Hospital, and I hope you got your BMD machine very soon. And I think your audit findings kind of reflect the current situations in all other MOH hospitals in Malaysia. I think so. Okay, we have some questions here. The first question is, Dr. Lim, what do you think about prescribing with calcium and vitamin D supplements? Do this help in osteoporosis patients?
Well, they do have a role to play in osteoporosis treatment, but they are not the most important thing that can help improve outcomes in our patients. So that's why, in terms, okay, so I don't have many patients to talk on to comment on yet, but from the secondary osteoporosis screening that we've done, we found that quite a number of our patients who post-hip fracture are vitamin D deficient. So there is a role to play in supplementing patients with calcium and vitamin D, because quite often for Malaysians, despite the sunny weather, or perhaps because of the sunny weather, we rarely go outside and we don't get sufficient vitamin D and calcium even in our diet.
Yeah, yes, yeah. Yeah, so I guess, Dr. Lim, you do check your patient's vitamin D level in Taiping?
Yes, we have to outsource it. It takes time to come back. So that's why the bone clinic appointment is important.
Yep. So following that questions, so then we will wonder, somebody raised the questions, if you're going to add on the calcium, vitamin D, plus minus our biphosphonate once a week, and the patient will get a medication burden, it will become a polypharmacy. How do you deal with it? Any strategy that you could advise us?
Well, the first thing that I guess the stereotype is that the geriatrician comes, sees the patient, and stops all treatment. So I think part of our intervention and part of the thing that we do in the comprehensive geriatric assessment is to rationalize the prescription and to de-prescribe when necessary. So yes, starting all this will worsen pill burden, and this is especially true for those with end-stage renal failure. You find that they are on so many medications. But in general, for most patients, after encounter with us, we also cut down a lot of their treatment and medicine, and this will also help to reduce their false risk.
Yeah, I have to agree with you. So we cut some and add some, depends on the importance of each medications. Yep. So, and did you run a falls assessment, and also are you looking into the falls in your bone clinic?
Yes, we are. We have just started the falls intervention, so there's still hiccups here and there. But the idea, we do have the presence of the occupational therapists and the physiotherapists, and every fortnight we have the presence of pharmacies as well. And we do have a template, the steady false risk factor checklist, which we fill up. So the idea is that the patients do get this false risk assessment. And why don't we do it inpatient? Because sometimes this inpatient, they cannot mobilize or they cannot weight bear properly yet. And so we do this intervention in outpatient.
Yep. I'm not sure whether the next question is suitable for our topics. One of our attendee asked, could you say a few words about falls in patients on antiplatelet or anticoagulants? Yeah, I guess this is a question.
I think the question is on this part. This statement made by them. Which doctor was it about that falls is not as dangerous as the risk of a stroke or something, right? I vaguely remember such a statement. Well, if you have any experience with managing falls in an older person, then you will change your mind on that statement.
Yeah. Yeah.
But I don't quite remember what was the statement exactly. I don't quite remember, but basically, no, falls is more dangerous.
You mean, I think that what you mean is you have to fall 265
yes.
times. This is what you mean. You have to fall 265 times in order to consider stopping the anticoagulation or something like that. Is it what you mean? Yeah.
So if you recall, I mentioned that 15% of all falls, 10 to 15% of all falls result in hip fractures. And hip fractures are a big complication.
Correct. And I have to say, congratulate to your orthopedic colleagues, it's just amazing. 90% of them, 80% of them actually get operated or something. The numbers is amazing.
Yeah, so I was very conscious.
Yep.
I worry that, my intervention might actually prolong length of stay because it's very heterogeneous.
Yeah.
Orthogeriatrics care. You find some studies that say length of stay increases with orthogeriatric care. So I really was very conscious of not trying to prolong length of stay. Yes.
Yep. Back to the questions on vitamin D, I listened, you mentioned, so you can't use calcitriol in Taiping. So
I can.
Oh, okay. But what do you think? Because there's a question asking, what would you prefer, vitamin D3 cholecalciferol rather than calcitriol in a vitamin D deficiency management?
Okay. Well, calcitriol or rather activated vitamin D is good for supplementing vitamin D. But when we are supplementing mega doses of vitamin D, there's another problem to consider, that we can overdose them with vitamin D and they can become hypercalcemic. So in this case, well, I'm not the expert in this, but in this case, I would feel safer with an inactivated vitamin D, so that there's at least a negative feedback pathway to prevent patients from being overdosed with vitamin D. I could, for example, increase the dose of calcitriol for my patients, but at what level does it become overdose instead of treating their deficiencies?
Yep. There is no mechanism to check back, you mean? Like how? Yep. Okay. To Orthogeriatrics, Dr. Lim, there's some questions asking you any prevention tips for osteoporosis?
Prevention tips for osteoporosis, basically because you build up bone mass when you are young. So from right now, you want to get yourself to expose to more sun, do more exercise, increase your vitamin D intake, and basically be more active overall. And that should help you improve your bone mass for future days.
Yep. Okay. And there are, I guess we almost near. There's a question, so I think it's a personal question for you, whether your system capture one of our participant mother who had sustained a fracture. But I guess because you mentioned some years ago, so I don't think it's captured. You started your service early this year, right?
But the first bone clinic appointment was in May, if I'm not mistaken.
Okay.
Yep.
All right. It's okay. We will attend to her personally. Yep, I guess that's it. If there's no more questions,
I actually saw someone raising his hands repeatedly, some Jason Ong or something.
Oh, really?
I am
sorry, I don't see any. Is there any? There is a question about how about using body composition analysis to check muscle level in fall prevention. Is there something about our sarcopenia muscles measurement? I'm not sure.
I
Oh.
guess so. But muscle strength and balance when it comes to falls is related to something functional. So yes, so using technology, you can assess bone mass, but it cannot substitute a proper functional assessment when it comes to strength and balance.
Correct. So we still back to our frailty assessment. Yeah.
Jason almost
good.
again.
Oh, really? Oh, okay.
No, I don't know.
Well, seems like attendees like to ask about drugs. So there's another person asking, calcium supplements worsens constipation and also risk of calcification with arteriosclerosis. What is your take on that?
Okay, so first of all, with regards to constipation, well, if you follow my rounds, you will know that I very regularly start. For all patients, in fact, the first question, one of the questions I will ask them is, can you pass motion well? So we are very conscious of the fact whether patients can pass motion well or not. So with regards to the other question regarding the risk of calcium supplementations causing arteriosclerosis, I guess the concern is that some people, or you might have read somewhere that calcium, when supplemented through diet, causes less risk of arteriosclerosis as opposed to calcium supplementation, right? But we are talking about the group of older adults here. I cannot back it up with any data or what, but basically, I would think that, at this point in time, the risk of arteriosclerosis is not going
it's not very strong.
As significant.
Yep. I think this will be a good question. So Dr. Lim, how would you consider palliative care for hip fracture? In what type of palliative care did you face that problem in typing so far, palliative?
So far, no, but I've had experience in palliating patients with hip fractures in for example.
Okay.
And
would you like to share with us? Yep.
Well, my worry about this talk is that it covers so many areas that I'm afraid that they'll come to an area that I cannot answer. But in short, palliative care is a whole big topic of its own, and I guess the simplest way to say it is I think in patients with for palliation, we often don't address pain well enough, number one.
Yes.
And number two, we are not just treating the patient, we are treating the family also. And it's important then in terms of our treatment, right, to not forget that. And very often you need a lot of communication that to address their needs. You might not be able to address them all, but if you communicate information properly to the family, they will be empowered to do or at least know what needs to be done. I'm sorry, I cannot give very specific tips.
I agree with you. This not it's not in the context of our topic today. Yeah, it's all right. Okay. I think we thank you again, Dr. Lim. Thank you for your talks. It's excellent. Yeah, thanks for your time to share with us. I think we shall end our webinar today. So looking forward to the next week. Thank you so much.
Thank you everyone for joining the webinar today. We'll have a very exciting topic for next week. Please do join us next. There won't be any QR code for us to scan for the CPD point. It will be keyed in manually by our team. So, and the cert will be emailed to everyone by the end of this month. Thank you.
Okay. Thank you.